This is a case about a 68-year-old lady with rest angina for 1 hour, and I was called at 1 a.m. in the night. Usually I tend to thrombolize the patient and then do the procedure next day, but they were very keen that we want to do this procedure. ECG showed acute anterior ST elevation, anterior wall MI. Echo was reasonably okay, EF of 40%. I always look for MR and VSD in all my primary angioplasty patients. Patient was loaded with prasugrel, aspirin, rosuvastatin. We started the procedure, and circumflex was tortuous, was reasonably okay. And there was a tight lesion in the mid-LAD with thrombus. And the right coronary was reasonably normal. So I counseled the relatives that we'll go ahead with the procedure. So she kept on telling me, can't we do it tomorrow morning? I said, I'm here to do primary angioplasty. She said, no, today is a day of Amavasya and not be able to get a good result. So, let's postpone it by a few hours, and we'll be there in the. So it's no moon day. Amavasya is no moon day. No moon day is not. It's supposed to be non-auspicious. So I said no. We need to do it because you have chest pain, and we have no other way to do it. So there was a tricky left main ostium, left coronary artery could not be cannulated with EBU 3.5 guiding catheter and JL 3.5 guiding catheter. So we had to use AL1, which was successfully used to cannulate the left coronary artery. Filter FC wire was used to cross the lesion. Pre-dilatation was done with 2.5 into 15 millimeter traveler balloon. No problems. Then lesion into 23 millimeter expedition stent, post dilated with 3.25 into 12 millimeter NC balloon. All looked good. There was a good TIMI grade 3 flow. Patient was pain free, and we said we'll take one more view. So this also looked fine. So we said that everything is okay. Time to go home. Remove the wire. And after removing the wire, there was initially first shoot did not show any flow in the mid-LAD onwards, and the second shoot showed boom. There was no flow beyond left main in the LAD as well as circumflex. And then patient started getting chest pain. So she kept on telling me, I told you, there will be complications. This is a day of Amavasya. And she started scaring me. I said, I always tell my patients, you chant Gayatri Mantra. She was a Brahmin. You chant Gayatri Mantra and we'll do the needful for you.
Sir, I would be chanting more than Gayatri Mantra after looking at this.
Sir, can we just have a quick 1 minute discussion? What could have happened?
I'm going to open this to the house. What do you think has happened here? So let's take a vote on that, and let's start with choices. What do you, so
heparin.
Go back one picture, play the picture.
It's an undercoagulation, and it's a catheter thrombus.
So catheter thrombosis because of heparin. Florim.
Yeah, I think we have to make sure she received enough heparin.
So suppose I tell you that the ACT is 320 at this stage.
So LMCA dissection progressing.
Dissection, yes.
She was 68 kg and we had given 7,000 units of heparin. She was given 60 milligram prasugrel, 300 milligram aspirin.
This shot prior showed LAD occluded first.
So
that's why I
just go
said
to the prior shot.
I'll go to the previous shoot. So here LAD is, go to the next. Yeah.
So just
So this was after removing the wire.
LAD is closed
Yeah,
now.
exactly. LAD is closing down. So this was the first thing. We realized that there is something going on.
So next shoot, the first clot went into the LAD, and then second shot it closed the circumflex. Because why I am saying this, if it would have been left main dissection, your previous two shots were showing left main very clear. I was always looking at left main because it was a AL catheter. So that's why I thought this is
The
a
AL catheter is actually, at least,
Even in that view, there is a left main dissection in the
gives you
downward.
a possibility that this could be a left
In the
main
previous view.
dissection. It is spiraling down and going down both ways. So therefore, that is I understand your proximal flow. And the counterintuitive argument would be that, hey, we are seeing it proximally, so this is happening only distally. So it is, as Florim said, it is maybe the heparin which is underdone or something. But I would, because of the AL catheter, I'm trying to imagine that I'm seeing some flaps, but I would really think in terms of a left main dissection.
We could also consider HIT, heparin-induced thrombotic, maybe some.
Yeah, but usually prior exposure to heparin comes in. I thought of that as
I
well.
mean,
Had you
the
done ACT?
dissection is not very confirmatory,
Not
there is
at all,
just a
not at all.
doubt of dissection.
Had you done ACT? ACT was done?
Yeah, ACT was done, 300.
Okay, let's resolve the mystery.
Okay.
Sir, once in a back, there is a dissection in the left main in the downward direction, which is very,
So-
very much visible.
So we think,
So first-
we can imagine a flap.
Yeah.
And
This looks like.
So first episode, gross embolization from there and the no reflow. Second, anatomical flap closing the LED ostium, as well as some spread into the L6.
Okay. So I told her, relax. And so I wired the LED. No, we need to wire LED as well as the circumflex artery. So I wired the LED. I always think of thrombus rather than anything else in primary angioplasties. There was a thrombus load to start with, and I had no reason not to think that it was not thrombus. So what I did was, I wired LED, I wired the circumflex as well. And then what I did was, I had a round of aspiration catheter, both in LED as well as in circumflex. I gave intracoronary tirofiban, and I kept on giving nitroglycerin and nicorandil. A patient had hypotension, systolic blood pressure of 40-50 when the first shoot was taken, that left main shoot was taken. The patient was put on inotropic support. The blood pressure came up to 100, 110. Kept on doing it, kept on giving intracoronary tirofiban, aspirating the thrombus from the LED.
did you get any thrombus? Or you were
I
just
did-
aspirating?
I did get thrombus. And you can see here at the left main, you can see some thrombus.
There will be thrombus.
Yeah, no.
You give it time, there will be thrombus.
No, the things were very quick. There was, you need to be extremely quick when the patient is sinking, when there is some this sort of complication. So I kept on doing it, the flow started improving, LED flow improved a bit. Again, you see the thrombus there at the ostium of the circumflex. And then it improved reasonably, the flow in the LED.
So there is one other possibility, which you all don't actually see that often, because in Mumbai practice, I know that you all supposed to use New York guides, but for the less privileged operators that we are in other parts of the country, where we use a lot of Oxford guides, you can have pre-existing thrombus from the guide, which you can inject by a forcible injection into the system.
Yeah.
And that is a possibility
Possible.
that one has to keep in mind.
That will happen before stenting only. Like,
No,
is this
it
a
can
kind of-
happen. You see, normally, and it is our experience, that the operator is usually most gung-ho about getting a good final shot. So he gives a forcible injection to try and prove that he has done a great job. And at that time, we've had this problem in the carotids, we've had this problem, because especially with O guides, and if there's an intramural clot within the guide catheter, it can get disclosed.
Everything was new. So everything was new. So finally I could get this. After a lot of deliberations, a lot of intracoronary tirofiban. There was still a lesion, a thrombus or whatever, a plaque at the ostium of the circumflex, and the patient still had pain. So what I did was I decided to stent it with a 3 into 15 millimeter stent. So this was the result. Now this was a reasonably good result, but patient still kept on complaining.
There is a dissection.
Yeah. So there is a dissection now which is clearly seen, which was not seen before. So at this point of time, I decided to stent the left main. So I decided to stent left main to LAD. And I decided to overlap it with my LAD stent. So decided to stent left main to LAD with 3.5 into 32 millimeter expedition. And we did a pot with 4 into 12 millimeter balloon. And this was the final result. Patient was pain-free. So I told her, this is Amavasya. Still we got a good result. So she said, it is not you who got the good result. It is my mantra. Gayatri mantra which got the good result. So, patient pain-free, inotropic support was tapered in 6 hours. Discharge after 2 days, doing fine at 6 months follow-up with negative stress test. So, the message I want to convey here is no angioplasty is over till your last shoot. Maybe no angioplasty is over for next 24 hours. The complications can occur. No angioplasty is easy, especially if you are doing it in a primary angioplasty setup. But if the complications like this occur, I think you should go by your instincts rather than the theory or rather than whatever is there in the books, and you need to make quick decisions and do the needful for all our patients to save the patient. And lastly, we never miss a chance to kiss or hugging what Ankur and Rahul has said, left main. So, we had a chance here to hug and kiss left
I think
main.
you should add one refrain. Try to avoid using very aggressive guide catheters if you don't need it.
Yeah.
I mean, that is to
Anil,
me.
there was no way I could have cannulated without AL1. So AL1, I had to use AL1 in this particular.
In terms of the learning, and it's very easy to be, smart looking back at these cases, but you had an angiogram with a wire down with good flow in all branches, and then you took the wire back to do a check, a final. I personally don't do that, especially with an aggressive guide. Once you then had that no flow down the LAD, I think it's intravascular imaging, it's IVUS, because if the cause of that no flow was a dissection, more contrast propagates it. If it's a no reflow, it doesn't help you. So if you put an IVUS down and identify you've got no distal and no proximal edge dissection, then you know that's not the cause of it. So those are the things that I would have done differently.
Yeah.
But
But
are we
God,
sure?
one thing. Linear dissections can even be missed by intravascular ultrasound.
Yes, but I think if you had just left it after with the wire down shot and finished.
Florian wants to say something.
But are we sure this was the dissection from the beginning? Because I'm sure he was nervous. so
I
that-
think if you go back
the dissection
and see
could
some of
have
the
happened.
earlier views,
No, but
we could imagine a
The
flap.
best dissection was
Some
seen
other
only
people
in the
also
last
imagine.
shoot.
Can you go up to the previous shoots?
Yeah.
So, as Sir is rightly saying, there's some
because the
haziness, and
dissection
retrospectively
which
we are
closes the
thinking.
left main.
I think this looks more like a thrombotic occlusion.
Yes,
and
I
wonder
think so
about
too.
Yeah,
whether the
I
heparin-
agree. It was more thrombotic occlusion than the dissection.
We had a stage of where the heparin.
But believe me,
heparin's
even
very hard.
proximal dissections,
heparin-
we have seen distal thrombosis happen.
Heparin's very hard to manufacture, and there was a batch last year where we were given doses of heparin and checking SET, and it was not therapeutic.
But here the ACT was therapeutic. It was 300.
300. ACT was 300.
That-
But,
Okay,
but
well,
wait,
that
wait,
stops
wait,
that theory.
wait. But
That,
no. Sorry.
Florian.
Do we? No. But this is really very important to discuss. Does an OCT of 300 guarantee the absence of thrombus? If that was the case, then life would be easy. But it's not the case, because you can have a huge thrombus with an ACT of 300. Was the patient on antiplatelet therapy?
Yes.
Before.
Not before. We
I
know
had
that-
before, because the antiplatelet therapy you give at the table, it will act tomorrow. So that's the problem.
No. We gave it 2 hours in advance. Antiplatelet therapy was received 2 hours. in
Prasugrel
advance.
2 hours is good absorption.
Yeah, good absorption.
Okay, one
Apparently not
final
enough.
comment from
So
the audience. Then
when
we'll
we're
move on.
not sure, if it's a dissection or a thrombus, what's the harm in standing from the left main to LED straight away?
No, he did that finally because he
Finally.
was not. He was thinking about it, but he was not
Yeah.
convinced that
Yes.
there is a dissection.
Agreed.
We all were,
Yeah.
but we are working in hindsight.
Yes,
So we
absolutely.
have the privilege of being watching through a retroscope.
So, absolutely, sir.
Prospectoscope.
putting
He
in
was
a-
not convinced.
Situation in the night is different.
Absolutely. In a primary
While
situation,
operating,
it's-
situation in night is
Bell.
totally different.
Next case.
Right.
Red case.
I think we give him a big hand. And in future, one moral of the story: on moonless night, no primary angioplasty.
So finally, did
Is
you
there
kiss
any
her?
beer at this gig?
Did you kiss
Any
her?
beer?
Finally.
Where's the beer?
Did you kiss her? Finally.
Colm is making a point. He said you called it a movie night and there's no beer. So he's made a very important point here.
Sir, I think that LCX lesion was the IMH mimicking CAD.
That is
and,
true.
And that's
that is
the
true. In fact,
point.
that is a giveaway.
Yeah.
That once you're, because if there is no residual thrombus which is causing that, then that is propagated dissection.
Next.